What I'd like to do is introduce the other three panelists and allow them some time on some reflection before we open to the whole group and have the committee start with their questionings in this area. So I want to start with introducing Dr. Ellen T. Chang, Principal Scientist and Epidemiologist in the Center for Health Sciences at Exponent, Inc., which is an international science and engineering consulting company in Menlo Park. She's also a visiting professor at the Sun Yat-sen University Cancer Center in China and teaches in an adjunct capacity for the Department of Epidemiology and Biostatistics at the University of California, San Francisco. Dr. Chang provides scientific consultation on the potential human health effects of various chemicals, air pollutants, metals and metalloids, fibers, pharmaceuticals, medical devices, electromagnetic fields, and nutrients. And she has conducted epidemiologic studies of the risk of malignant lymphomas, nasopharyngeal carcinoma, hepatocellular carcinoma, and other cancers. Dr. Chang earned her undergraduate degree at Harvard College in 1998 and her doctorate degree in epidemiology with a minor in biostatistics from the Harvard School of Public Health in 2003. She completed a postdoctoral fellowship in medical epidemiology and biostatistics at the Karolinski Institute in Stockholm, and she worked at the Cancer Prevention Institute of California and the Asian Liver Center at Stanford University before joining Exponent in 2012. Dr. Chang.
Thanks very much, Ned, and thanks also to Dr. Samet and Dr. Morgan for your informative and thought-provoking presentations today. Thanks also to the committee for giving me this opportunity to reflect on the issues of evidence synthesis and application when it comes to PFAS. As noted in Ned's introduction, I'm employed by Exponent, which is a science and engineering consulting company. So I want to disclose up front that I and others at Exponent have received funding from companies that produced or used various PFAS. As an epidemiologist, making recommendations for patient care is really outside of my expertise. So my reflections here are strictly from the point of view of someone who spends the bulk of my time looking at whether causal health effects of specific exposures on specific human health outcomes have been established. That is the sort of strict yes or no question, rather than making clinical practice recommendations. My point in emphasizing this distinction is to recognize that there is a critical difference between these sorts of activities. Epidemiology generally involves identifying, synthesizing, and weighing the evidence to come to a conclusion about causation, much as Dr. Samet described, often following the framework that was laid out by Sir Alston Bradford Hill and the 1964 Surgeon General report that Dr. Samet mentioned. So this pertains more to the evidence synthesis part of this panel discussion, and not so much the application part of the topic. And as Dr. Longnecker and Dr. Savitz noted in the prior session on PFAS health effects, when it comes to the epidemiology of PFAS, there's still a lot of uncertainty regarding causation, and there's variation in the quality and strength of evidence when it comes to supporting a potential causal effect of any given PFAS entity. There are several health and regulatory agencies, including the U.S. National Toxicology Program, the EPA, the Agency for Toxic Substances and Disease Registry, and the International Agency for Research on Cancer, and others that have conducted evidence syntheses on PFAS, following the general approaches described by Dr. Samet. To my knowledge, none of them have concluded clearly that any specific PFAS is established as causing a specific human health effect. Some of them have reached conclusions about presumed effects or possible effects, but as far as I know, they haven't concluded that there are known effects. So this epidemiological uncertainty sets the stage for a really difficult question for healthcare providers and also for this committee in terms of making recommendations for those providers. Do the doctors and the healthcare providers want to go strictly by the epidemiology when it comes to established causal effects And do they want to strictly follow recommended disease screening and monitoring protocols, bearing in mind, for example, that there is no widely accepted US PSTF recommended screening strategy for kidney cancer. And it's also not clear how doctors and nurses would monitor for reduced anti-vaccine immune response, for instance. Or do healthcare providers want to be more precautionary, and even without clearly established causal effects or accepted screening and monitoring strategies, should they instead guide their patients based on evidence that isn't quite clear-cut? That is it really a yes-no question of causation when it comes to providing patient care and addressing patient concerns? Probably not. So from an epidemiological perspective, I think that this situation may end up being one that requires more individual, provider-specific judgments, and perhaps providing guidance on how to communicate and take action in the face of uncertainty, as opposed to providing generalized recommendations for clinical practice, at least in terms of evidence-based testing and screening and monitoring. But I'll leave it there with that open question.
Thanks very much, Dr. Chang. That was great. Let me move on to introduce Dr. Nicholas Chartres, the Associate Director of Science and Policy at UCSF's Program on Reproductive Health and the Environment. He is focused on environmental health research translation methods and the promotion of evidence-based policies to prevent exposures to harmful environmental chemicals. In this role, he oversees the Navigation Guide Working Group, which is focused on increasing the knowledge and awareness of systematic review methods in environmental health and policy decision-making arenas. Dr. Chartres is part of the World Health Organization, International Labor Organization Joint Working Group on Occupational Health Systematic Review Methods, which aims to estimate the global burden of work-related disease and industry. Dr. Chartres.
Good afternoon. Can you hear me clearly?
Now we can.
Wonderful. Thank you.
Now we can.
Can you hear me clearly now?
Yes, sir. Thank you.
Thank you. Apologies. I'll attempt to use my speaker and change my audio in between the panel speakers. Thank you, Professor Samet, and also Dr. Morgan, for your excellent presentations. And thank you to the Academies for the invitation to be part of the panel today. My reflections are firstly on Professor Samet's presentation and focused on, I guess, how the committee can achieve their charge to assess the strength of the evidence for the spectrum of putative health effects suggested by human studies. And obviously this is an incredibly broad scope and challenging task. And my immediate thought and consideration is using and identifying validated methods that have already been used by the Academies in this process, that have been recommended by the Academies as well. I know that recently the Academies evaluated or gave comment on the validity of the EPA's TSCA systematic review method and the methods that were recommended by the committee were those of the NCP, OHATS and the National Toxicology Programs, Office of Health Assessment and Translation, at the University of California, San Francisco Navigation Guide Method, and also the IRIS program within EPA. I think these are excellent starting points when considering evidence synthesis of the human studies. Understandably, there are some challenges in terms of the time and also the scope of the reviews that need to be considered within the next few months. Recommendations on that, I certainly think that there's the opportunity to use authoritative bodies that have already conducted reviews on the prioritised PFAS across various health outcomes, such as the International Agency for Research on Cancer. And I also think there's opportunity to do scoping reviews of systematic reviews that have already been conducted to help the Academies in achieving this evidence synthesis and summary of the evidence. If the Academies does choose to do systematic reviews of or use systematic reviews that have previously been conducted, There are options to assess and evaluate the risk of bias of these methods, and if there is concern about the validity of these methods, there's also the opportunity to use emerging syntheses methods such as rapid reviews, which have been used extensively by the Cochrane collaboration throughout the outbreak of COVID-19 to inform the most effective strategies for COVID-19 within really rapid timeframes. One other thing that obviously sprang to mind when thinking about the scope of the body of evidence that needs to be reviewed, a number of the PFAS that are currently on the CDC's National Report on Human Exposure to Environmental Chemicals overlap with the Endocrine Disruption Exchange database, which is a database that was published this year of all PFAS, all health outcomes of a number of the PFAS that are on the CDC's PFAS of concern. These were evaluated using systematic review methods, so I immediately think in terms of assisting the academies in this evidence review that such a database is certainly considered. Thank you.
Thanks so much, Dr. Chartres. And then finally, and certainly not least, it's my distinct pleasure to introduce Dr. Holger Schünemann, who's a tenured professor in the departments of Health Research Methods, Evidence and Impact and of Medicine at McMaster University. From 2009 to 2019, he completed his 2 terms as Chair of Clinical Epidemiology and Biostatistics at McMaster University, widely considered the birthplace of evidence-based healthcare. He had trained in respiratory and exercise physiology and internal and respiratory medicine at the Medical School of Hanover, and lung biology, epidemiology, internal medicine, and preventive medicine and public health at the University of Buffalo, State of New York. I think he completing these in 1997 and 2000. He was on faculty at UB and from 2007 to 2009, interim chair of epidemiology at the National Cancer Institute in Rome, Italy. He has been advisor and chair of many guideline expert groups for WHO, the European Commission, Ministries of Health, other government organizations, and professional societies. He's director of Cochrane Canada and the McMaster Grade Center. He maintains an active internal medicine practice, fulfilling his passion for patient care, and he always ensures that his research is people-oriented. We're not quite brothers from a different mother, but we're cousins from different families. I don't think I've ever been part of an evidence-based methodology effort that Holger and I weren't on in the same room at the same time. So thanks for being here, Holger, and it's great to see you as always.
Thanks, Matt. Great pleasure, and thanks so much for the invitation to be part of this panel today. So first, I have no direct financial conflicts of interest to declare. I do not do any research related to PFAS, and as Dr. Samet, I'm probably pretty naive in that regard. But and second, thank you to Dr. Samet and Dr. Morgan for providing the overview on evidence synthesis and evidence integration and making recommendations using a great approach, respectively. The evidence integration challenge is one that needs to be solved, and I believe progress is made by groups like the Evidence-Based Toxicology Collaboration and similar collaboratives. Dr. Morgan nicely described the criteria that determine the direction and strength of recommendations, which means that recommendations are influenced by many desirable and undesirable consequences. Obviously, she did not have time to reflect on all the work that the great working group has done over the past 2 decades. But related to recommendations, they are, I think, quite foundational, described in the work of the great evidence to decision frameworks that conceptualize and operationalize the key criteria beyond only health effects that influence a health recommendation. So when it comes to environmental exposures, this is particularly relevant in terms of thinking about desirable consequences that are not health related, or may indirectly be health related, because otherwise we would often simply ban any production of any material that leads to environmental exposures and direct risks. Or at least in theory, we would do this. These consequences should also, in theory, but maybe also in practice, be laid out early in the process so that health recommendations are understood by the target population. What I'm referring to is that we should be thinking about desirable consequences, such as that people have food on the table, in order for users of recommendations to understand why such substances even exist in the environment. This is well described elsewhere, but I think it's particularly helpful or relevant in the field, in any field that has to do with toxicology. So toxicology is is taking a special case because these potential benefits are not necessarily considered by those who make recommendations. And, that is really, as I said, it's really critical. The ETDs the evidence to decision frameworks actually can help with doing this. So, and I think it will be helpful to at least describe for users of recommendations what the societal benefits of still accepting not only PFAS, but environmental exposures actually are. What is also critical is that the right evidence to decision frameworks should actually be used. Are we talking about a clinical recommendation with a population perspective, or a public health and health system perspective? And in GRADE's view, at least, making this transparent to those who act on actionable statements or make decisions is critical. And then what strikes me always as particularly relevant is the evaluation of the directness of the exposure to the actual health outcomes, as was mentioned earlier, and how this directness can be evaluated in a structured way that is using a valid way of making indirectness transparent. I would just like to emphasize very quickly that we think GRADE is not RCT focused or based on that paradigm, but it can be easily understood that way. And that is part of a communication mistake that the GRADE working group has made. Indeed, GRADE, I think, has been operationalized, or is one of the approaches that has operationalized the use of non-randomized studies in a quite detailed way. So, well, I stop here, Ned. There's a few other points that I possibly could make later. But I'll for respecting others and the time, I'll stop for now.
Thanks, Holger, and I'll come back to you if it looks like we have more time. And I do want to celebrate and recognize the work that GRADE has done in allowing the assessment of other kinds of evidence studies, the approach actually including qualitative research through GRADE CERQUAL, the increasing evolution of the methods to address a lot of the things that we're wrestling with. I wish we were a little farther down the path in the interface between environmental exposure evidence and individual clinical recommendations than we are, and I know that you'll get there. So thanks so much. So let me, at this point, open it up. First to Kevin, since he raised his hand. So Kevin.
Thanks, Ned. I didn't want to jump in before you had a chance. Hope it's okay. I really found your talk helpful, Rebecca, and I was curious. This is, I raised the point after Professor Samet's talk about the second part of our statement of task, needing to develop these general principles for clinical evaluation and biological testing, given substantial scientific uncertainty. And I was just curious to hear your thoughts and/or any panel members on the extent to which the GRADE evidence to decision framework already kind of provides principles like that we could almost take off the shelf, or the weaknesses of what grade provides in that regard. So I was just curious to get your thoughts as an expert on that for that particular portion of our task.
Sure, no, that's a great question. And it's always positive to reduce redundancies, right? If things already exist. I think, we have a lot of analogous examples in different fields, whether they're coming from public health or coming from areas of clinical research for which there is very limited evidence. And so I think those examples exist in literature, and I'm certainly happy to share those at any time. But I guess that was what I had tried to capture, a bit. And I think just to emphasize, we know we're making judgments, and we're making judgments about a few things, the certainty of the evidence, as well as these other domains that contribute to decision making. And in each of those, it's not expected that you would always have evidence in the research, but you may, need to make the comments explicit that are coming up among, the panel, or needing to survey the groups that you're working with or trying to make guidelines for. And I'm sure other panelists have some insights as well. So I won't take that time.
Yeah, I'd love to hear from any others on the extent to which they think existing decision frameworks could provide the basis for the principles we're trying to develop.
Yeah, if it were easy, Kevin, everyone would do it. Dr. Chang, I was really taken by your comments around these are probably going to be decisions that are less based on causality and more based on trying to provide the best. Clinicians have the best tools to providing helpful information or guidance to patients, individual patients, because I think that is squarely one of our charges. And I liked that framing, and the advice would be in the area of uncertainty, but it kind of brings in that basic first sentence about evidence-based medicine, based clinical decisions on the best available evidence. And so I wonder if you could say a little bit more about how you see that playing out, because what we've heard from exposed individuals is that the majority of physicians provide no information and no guidance. And part of it is lack of knowledge, but if you took it to the extreme, it would be lack of evidence to support a recommendation other than maybe you should, filter your water.
Yeah, I think this actually relates also to Kevin's question for Rebecca. And I think her recommendation of just being explicit about the basis, or the quality of the scientific basis for making recommendations, from the committee to healthcare providers, and for healthcare providers making recommendations to their patients. I think providing evidence on how to, or providing guidance on how to communicate that, the evidence isn't clear, or it seems to be uncertain on these issues, but we have some, guidelines for you, or we have some recommendations that you could take on, on an individual level. I think, just being transparent about the quality of that evidence is important. And then I think then it becomes in some ways more of an exercise in communication than in planning specific healthcare actions or, patient testing procedures, and more about how to address their concerns, because they are valid concerns, and how to answer their questions. And then also, instead of just saying, well, I don't know, I don't know what to do about it. They're coming to their doctors with questions. I think I think they deserve an answer, but that answer may be, that the evidence is not solid. And then going back to the prior panel session where I think towards the end people were talking about perhaps addressing more issues of exposure reduction than medical testing or monitoring or intervention. That could be one pathway that is more evidence-based, although I admit I didn't listen to yesterday's session, so I don't know what conclusions were reached on exposure reduction. But I think there need to be guidelines on how to communicate and how to summarize the evidence to patients.
I appreciate that. Since there are not any other hands up, I have one other question, and then I'd love to hear Holger's other points. And it's for the entire panel. So one of the ways when I was in the practice of designing prevention programs to deal with the area of uncertainty was shared decision making with the patient or the individual and the clinician. And so I would ask the panel, do you see that informed decision making, shared decision making around the issues of we don't know, this is what we do know, and let's discuss what, within the context of your individual values and concerns, we should put together for you based on what we know, where that fits in terms of operationalizing evidence-based recommendations, particularly maybe in the setting of uncertainty and environmental exposures.
I'm happy to.
I'll make a comment. This is John. I mean, I think I thought about an analogy where an environmental measurement leads to clinical action. Lead exposure is maybe a useful thought exercise because we actually do take responses. We have a certain body of evidence. For such a complex set of environmental agents, unless patients make their way to very focused, specialized environmental health docs, I just don't see that decision-making model works. I mean, I think it's asking too much on the part of both the patient and the physician. I mean, I think there's many models of shared decision-making that are extraordinarily challenging. I mean, lung cancer screening is now a great example, but this one I just don't see as falling in that kind of niche. And a good contrast is lead exposure, where we know what to do at different levels of blood lead.
Thanks, John. Rebecca, you were going to chime in?
Sure. I think during the decision-making process, sometimes you'll find as you're walking through those factors, it'll become apparent where maybe the main shared decision-making happens, right? So you may be able to identify, there are a group of patients who would place a higher value on unknown harms and a lower value, or, handle less uncertainty or more uncertainty about the benefits. And that certainly can be coupled with the recommendation statement, and I think is helpful for the clinicians. I agree with John, decision-making takes time, especially out of, these clinical encounters, but I think there may be a way, again, to make that transparent with the recommendation statements so that the practitioner knows, okay, I'm on the lookout for patients who may have these specific values. This is where it deviates from our conditional recommendation, or these are the conditions.
Thanks. Holger?
Yeah, sure. So I wanted to comment on that particular issue. I don't think that many of the environmental itself to shared decision making. The COVID-19 epidemic or pandemic is actually a good example for recommendations based on work that we are just doing, compiling any health. We've completely failed to communicate appropriately with the non-health professionals. What I think we are talking about is not real shared decision making on what we call things that are understood by the public. And that may lead to some degree of shared decision making, but I think it really starts much at a much higher level. And that is formulating recommendations that are not targeted to health professionals, but to consumers or public citizens. And so that's the first point. So it's not necessarily shared decision making, it's actually recommendations that people understand. And then my other points are indirectly related.
Thanks, Holger. Nicholas?
Thank you. I think it's critical, and I think it's one of the systematic weaknesses in many guideline development processes where consumer participation is limited and it's thought of or tacked on at the end. And I think it's critical that we don't rely on guideline panels substituting their own values and views for those of patients or the beneficiaries of an intervention. I think it's particularly important when we're thinking about environmental communities and environmental justice issues where we may have communities that have cumulative impacts, both from chemical exposures and from other extrinsic factors that may exacerbate the potential harms that they're facing from these exposures. And I think having the voices of these patients and beneficiaries involved in that decision-making process from the outset when we're forming the recommendations is a critical part of the process. I think the social cultural acceptability of an intervention is very much dependent on that input. And I think without having that type of engagement, we're going to find that we're going to get a limited level of acceptability across a broad population, and particularly in the communities we most want to protect, so those that are carrying a disproportionate burden of environmental exposures. So I think it's an important consideration about community engagement from the outset.
Thanks, Nicholas. I think that's an important point and something we've actually been trying to do, and I appreciate the Academies for really supporting that inclusion part. Holger, I'm going to turn it finally back to you for your last couple of comments, and I appreciate everyone being here.
Yeah, thanks, Ned. I wanted to reflect on something that was said earlier. So I think it is not always important to know mechanisms, and GREAT is particularly explicit around the fact that mechanisms are indirectly considered. In particular, when there's certainly the evidence is high or moderate, because if we'd like to find a mechanism for something, and related to that is that that this is one of the reasons why biological plausibility are not a domain in this certainty of evidence assessment in GREAT, differently from Bradford Hill. GREAT, fully acknowledged, completely in agreement with John. GREAT is a further development of the Bradford Hill viewpoints. There's no doubt in my mind, and I think all of these systems are. The other thought for consideration here is, in the context of insufficient evidence, in my view at least, is how we use expert evidence in this context. And that may not only relate to health effects, but also to other criteria that influence a recommendation or decision, for instance, in the evidence to decision framework. And then finally, it may be relevant at some point to review criteria for when it may be reasonable to make good practice statements related to environmental exposures, for which we urged, obviously, and are being refined. One of the criteria there is that indirect evidence clearly points towards net health benefits or harms when making a good practice statement. And I think that will be relevant for this, could be relevant for this committee to really think about, so health recommendations might be appropriate. Thanks, Ned.
Yeah, important point. I think, a great place for us to end this session. I really want to express my appreciation, and I know I do so for the entire committee, for the expertise around the table, the thoughtfulness and work you put into your presentations and comments. And I want you to know that it's a very helpful session, especially for Kevin and his work group, which I'm on, about how we think about putting together the right framework for our evidence synthesis and our evidence to decision framework approach. So I thank you all. It'd be really interesting at some later point to get your feedback on the report when it finally comes out. I really thank you for joining us. And again, Holger, it's great to see you. I think this ends our formal presentation session, and I'm going to move right into the open comment period. People providing comments today have registered in advance, and we appreciate that. We're going to ask you to keep to 3 minutes. That's really, to be fair, because that's the way we've and consistent, the way we've approached other people in the in the public comment area. I have a list of names. I see one person on my list, and of course I'll ask and make sure that some of the other folks aren't hidden somewhere away from my view. But Katie Pelch, I'd love to turn things over to you.
All right, thanks. Thank you again so much for your attention to this very important public health need. My name is Dr. Katie Pelch. I'm an assistant professor at the University of North Texas Health Science Center, and I have been working at the intersection of PFAS science and policy for several years. As outlined today at the beginning of the session by Dr. Samet, in order to fulfill your task to review the health evidence for PFAS, one of the very first steps you must do is to identify the evidence. And I just wanted to take this opportunity again today to remind the committee about the wealth of information that myself and colleagues have compiled in the PFAS Talks database, which is now available online. And you can find that at pfastalksdatabase.org. And Dr. Chartres mentioned this in his comments as well. This is a publicly available database that was developed using systematic evidence methods, and it will fulfill this first step in identifying the available health data for 29 different PFAS. To Dr. Samet's points earlier, the database separates the available studies by evidence stream, including the human, animal, and in vitro studies, so that the relationships between these evidence streams can also be evaluated. I'd like to tell you just broadly about the work that we've done to date in compiling the PFAS Talks database. So the database was focused on 29 PFAS that are commonly measured in environmental matrices, human biomonitoring, and laboratory research, or they were chemicals that were of concern to many of our stakeholders. We did not include studies that have only evaluated PFOA and PFAS, but that could be added to the database if needed. Our original search was conducted in May of 2019 and returned nearly 12,500 studies, of which 742 were ultimately included because they evaluated the association between one or more PFAS and a health or toxicological outcome. And these are the data that are currently viewable in the online interactive database. Right now, we are processing the additional 2,500 studies that were retrieved in a literature search update that we ran in January of this year. And we're expecting to add an additional 335 studies to the database, including nearly 200 human epidemiological studies. So your task is not small. This has taken us a few years to put together. But I do want to highlight that all of this data is publicly available on the database and in the supporting information, and that the database was put together using established systematic review methodology based on that from the National Toxicology Program. In addition, we have supplemental files of studies that measure exposure and biomonitoring studies that are available in the Open Science Framework website that accompanies the database. And I see my time is up, so I will stop there.
Thank you. Thank you so much, Katie. We appreciate the comments and appreciate the information. on the database and are pleased that it's publicly available. That's just great.
Can you put the address in the chat, Katie?
Mm-hmm. And it is just pfastaxdatabase.org.
Sorry, Nan.
Are there any other members of the public who have pre-registered to make comments with us? Seeing none, I will again thank our speakers who stuck with us to the end. A very great day today in both sessions, and thanks for helping move us forward in this important work.